Hello everyone and welcome again. So continuing our discussion about the clinical pharmacology basic principles class. Now we are going to talk about the drug distribution. So after the drug gets administered by the patient and after it gets absorbed from the site of administration into the systemic circulation, now it gets distributed into different body fluid compartments. And in this video, we will talk about the distribution into body fluid compartments and the factors affecting distribution. We also are going to talk about the volume distribution and the clinical significance of the volume distribution. We will also talk about the binding of drugs to plasma proteins and to tissue proteins and the clinical significance of the binding to proteins. So let's start. So let's start by talking about the water distribution in a human body. And we all know that 60% of body is water. So 60% of human body is water. And for an 80 kilograms person, this would equal to 42 liters. 60% would equal to 42 liters. And that's so total fluid would be in 80 kilogram person would be 42 liters, and that would be split into two main compartments: the intracellular fluid, and we also have the extracellular fluid. 2/3 of the total fluid would be intracellular, so 2/3 would be intracellular and 1/3 would be extracellular. So intracellular fluid would equal 2/3 of the 42, and that would be 28 liters, and the 1/3 would be 14 liters, and the extracellular fluid would be also divided into two compartments, and those are the interstitial fluid, fluid, and the plasma fluid, which is also called the intravascular fluid. So now we have intracellular, extracellular, interstitial, and intravascular. 75% of the extracellular fluid would be interstitial, so 75%, and that's 75% of the 1/3, which is 14. It would be equal to 10.5 liters of the 14 liters would be in the interstitial fluid, and 25% of the 14 liters would be in the intravascular, which is equal to 3.5 liters. And the drugs, when we give the drugs, they start by distributing into the plasma, and then depending on the volume of distribution of the drug, it might distribute to the other compartments. So it starts by the plasma and it goes up depending on the volume of distribution. It starts with the plasma, then interstitial fluid, then finally to the intracellular fluid. And for the drugs that are administered by the intravenous route, they skip the absorption and they would be directly into distribution. That's an important note to look for. Now let's talk about the factors affecting drug distribution. And let's start with the blood flow. So the blood flow to the tissues is different depending on the type of tissue. We have some tissues that, like the kidney, the brain, and liver, they have a high blood flow in comparison with the skin, adipose tissue, and skeletal muscle. They have lower blood flow than those, so they have lower blood flow. So the drug would distribute more to those organs, the kidney, brain, and liver, more than the skin, adipose tissue, because the blood flow is more to those organs. We also have the capillary permeability, and the capillary structure varies in terms of the fraction of the basement membrane exposed by slit junctions between endothelial cells. That means there is sometimes the capillary structure have a lot of slit junctions like that, and sometimes it has low slit junctions, so it would be like that. So the more slit junctions between the capillaries and the more the capillary is permeable, this would lead to the drug distributing more to the tissue that the capillary is giving blood to. Example would be the liver and the spleen. They have large discontinuous capillaries, meaning they have capillary structure like that. So it would be so the drug would distribute more to the liver and spleen in comparison with the brain, which have capillaries that are continuous and they don't have any slit junctions whatsoever. So the brain capillaries would be like that. And so the drug would distribute more to the liver in comparison with the brain. The drug would go through the brain either if the drug is highly lipophilic, or if there is active transport that make the drug bypass this continuous capillary. And the continuous capillary is called the blood-brain barrier in the brain. We also have, regarding the factors affecting drug distribution, we have the cardiac output is a factor. In patients with the cardiac disease, they have a lower cardiac output, so they would have a lower distribution of the drugs to their bodies. And we also have the degree of binding of the drug to plasma and tissue proteins. The higher the binding of the drugs to plasma and tissue proteins lead to lower distribution, because the drug is bound to the proteins, so it can't distribute more to the tissues. We also have lipophilicity of the drug. The more lipophilic the drug is, it would have more distribution to fluid compartments. And we all know, explained in the drug absorption video, that the lipophilic drug would cross membranes better than the less lipophilic drug, so it would have more distribution because it's going to cross the barriers better than the less lipophilic drug. Now let's talk about the volume of distribution. So the volume of distribution, also abbreviated as VD, is the apparent volume of water. So it is the apparent volume of water into which the drug is distributed in the body after it reaches this distribution equilibrium. So volume of distribution is calculated by dividing the total amount of the drug reach the systemic circulation over the plasma concentration of the drug after distribution equilibrium. So VD would equal to the amount of the drug available for distribution on the plasma concentration of the drug. And as we mentioned earlier, the drug distributes first to the plasma and then into the interstitial space and finally to the intracellular space, depending on the volume of distribution. So let's take some examples about the volume of distribution. So we have the first example, we have 90 milligrams of the drug are given intravenously, meaning they all are available for distribution. So 90 milligrams of the drug to a person. After a while, meaning after the drug reaches distribution equilibrium, we calculate the plasma concentration of the drug and we find it to be 30 milligrams. And now we calculate the VD, which is equal again the amount of the drug available for distribution on the plasma divided by the plasma concentration of the drug after distribution equilibrium. So it would equal to 90 over 30, and that's equal to 3 liters. So the volume of distribution of this drug is 3 liters, and we mentioned that the plasma would be 3.5, and then the interstitial space would be 10.5, and the intercellular space would be 28. So that this drug will be only 3, so it would distribute only to the plasma. So this drug would go into plasma only. The other example is that we give 90 milligrams of another drug, which is also intravenously, so all available for distribution, and after a while we calculate the plasma concentration and we find it to be 1 milligrams. We also do the calculation, so VD would be 90 on 1, so it would be 90 liters, and that would be greater than 42, which is all the body fluid available, meaning this drug will distribute to the plasma, to the interstitial fluid, and into the intracellular fluid. So this drug would go into all fluid compartments. Now let's talk about the clinical significance of the volume of distribution. First of all, the volume of this distribution of all of the drugs is available in resources like Google. You can find the volume of distribution for any drug by googling the drug name. Also, the volume of distribution is very helpful in deciding the management of a drug toxicity. Depending on the drug that the patient have toxicity with, if the volume of distribution for that drug is less than 5 liters, this means the drug is only in the plasma and we can use dialysis for that drug. Dialysis would be effective. If the volume of distribution of the drug that the patient have toxicity with is more than 42 liters, this means that the drug in all the body compartments, so all fluid compartments, and dialysis would be not ineffective. Dialysis would be ineffective. And if the volume of distribution between the 5 and 42, then decision depends on the situation. So decision of dialysis depends on situation that we have. Also, the volume of distribution is helpful in the forensic medicine. That's in identifying the amount of the drug that the patient take that was fatal to them. That's by the same formula, the VD would equal to the amount of drug divided by the plasma concentration, and we calculate the plasma concentration of the drug in patient plasma, and we have the volume of distribution from the resources, and we calculate the amount that the patient took. Also, the VD is helpful in calculating the loading dose that is needed for the drug to be at effective concentration, and that's from the same formula, VD equals amount divided by plasma concentration. And what is the plasma concentration desired? We would enter that into the formula, and we have the VD, and we calculate the loading dose from the amount, which is the same as the loading dose. Yeah. And finally, the VD is helpful in drug clearance, in calculation of drug clearance. So clearance, we have a formula that is clearance equals to 0.7 divided by the volume of distribution, multiplied by the volume of distribution divided by the T half, which is the half time. Now let's talk about the binding of drugs to plasma proteins. So most drugs, when introduced to the body, they are bound to plasma proteins, and reversible binding to plasma proteins sequesters the drug in no diffusible form and slows transfer to the vascular compartment, meaning the binding to plasma proteins would lead to lower distribution. So binding to plasma proteins would decrease the distribution of the drug. And the drug that is highly bound to plasma proteins have less distribution. The same again. The albumin is the major drug binding protein that's in the circulation, the albumin, and it may act as a drug reservoir. That's meaning as the concentration of the free drug decreases due to elimination of the drug, the bound drug that is bound to the albumin and the other proteins would dissociate from the albumin, and this would maintain the drug, the free drug concentration as a constant factor or constant fraction of the total drug in the plasma, and that would lead to prolongation of the drug action in the body. So now let's talk about the clinical significance of the binding to plasma proteins. So biological effect of the drug related to the free part. So the free part of the drug is the active part, and the bound part would be a reservoir, not effective. It would not it would have no effect on the body whatsoever. The binding of the drug to plasma proteins prolongs the duration of action because, as we said earlier, it would be a reservoir for the drug. The eliminated part would be so the reservoir would always supply the free part. So we have a bound part and we have the free part. So the more the free part decreases, the bound part would dissociate into supplying the free part. So if the drug binds to plasma proteins in high concentration, like warfarin, it would, like if the warfarin is 99% bound, the 1% is active. Any small displacement of the bound part by another drug that also binds to plasma proteins can lead to doubling of the free part and lead to toxicity. Meaning, if the drug is highly bound to the proteins and we use another drug that is also going to bind to the proteins, the other drug would compete with the first drug on the positions on the proteins, and it would lead to displacement of the drug from proteins, and it might lead to toxicity. So also, if the patient have hypoalbuminemia, so the albumin is low in that patient, like in liver disease, nephrotic syndrome, pregnancy, and you give them a drug that binds in high concentration to the plasma proteins, this might lead to toxicity because the proteins are lower than normal, so meaning that the free part would be very high in comparison with the patient that has normal plasma proteins. So this might lead to toxicity because the free part of the drug is going to be very high, and we need to dose adjustment needed. So we need to give lower dose to the patient that have liver disease or pregnancy, because the proteins would be lower than the normal person. Finally, let's talk about the binding of drugs to tissue proteins. So many drugs accumulate in tissues, leading to higher concentration in tissues than in interstitial fluid and the blood. And the drug accumulates in tissues by binding to lipids, proteins, or nucleic acids that are available in the tissues. And the drug may also undergo active transport into the tissues. And the tissue reservoirs may serve as a major source of the drug and prolong its action or cause local drug toxicity. The same with the plasma proteins. The tissue proteins also might act as tissue or reservoir for the drug, meaning when the free part decreases, the bound part will try to supply the free part. But they may also cause local drug toxicity to the tissue depending on the type of drug and the type of tissue affected by that drug. Example would be the acrolein. The acrolein is a metabolite for the cyclophosphamide. The cyclophosphamide is an alkylating agent used for anti-cancer therapy and used for some connective tissue diseases. So the acrolein is a metabolite for the cyclophosphamide, and the acrolein would accumulate in the bladder, and it would cause hemorrhagic cystitis when it accumulates in the bladder. So one of the side effects or adverse effects of the cyclophosphamide would be the hemorrhagic cystitis, because the acrolein, which is a metabolite for the cyclophosphamide, would accumulate in the bladder and lead to toxicity as a form of hemorrhagic cystitis. And with that, we reach the end of this video. Thank you guys for watching. If you want to support this work, you can by subscribing to the channel and liking the videos. If you want to support more, you can by subscribing to the Patreon link provided in the description of this video. And thank you for watching, and see you in the next videos. Peace.